dirty, slovenly, untidy woman. Infection or inflammation of the upper female genital tract. It's usually secondary to skank-like behavior, gonorrhea, or chlamydia. On ultrasound you are gonna get hydrosalpinx. The margin of the uterus may become ill-defined. Indefinite uterus is a buzzword. Later on you can end up with tubo-ovarian abscess or pelvic abscess. You can even get bowel or urinary tract inflammatory changes. Parovarian cyst. This is a congenital remnant that arises from the Wolffian duct. Wolffian duct. They are more common than you think with some. Intrauterine growth retardation cont. Intrauterine growth retardation cont. Normal kid, normal sized head, normal sized body. Vaginal septum is present 75% of the time. Corpus luteum. The normal corpus luteum arises from a dominant follicle, as I detailed eloquently above. These things can be large, up to 5-6 cm, with a variable appearance, solid hypoechoic, anechoic, thin-walled, thick-walled, cyst with debris. The most common appearance is solid and hypoechoic with a ring of fire, intense peripheral blood flow. Corpus luteum vs ectopic pregnancy. They both can have that ring of fire appearance, but please don't be an idiot about this. Most ectopic pregnancies occur in the tube. The corpus luteum is an ovarian structure. If you are really lucky, a times hint is that the corpus luteum should move with the ovary, where an ectopic will move separate from the ovary. You can push the ectopic away from it. Also, the tubal ring of an ectopic pregnancy is usually more chocnic when compared to the ovarian parenchyma. Whereas, the wall of the corpus luteum is usually less echogenic. A specific, but not sensitive, finding in ectopic pregnancy is a RI of 0.7. Ectopic corpus luteum. RI 0.7, RI 0.4 minus 0.7. Thick echogenic ring of fire. Moves separate from the ovary. Thin echogenic ring of fire. Moves with the ovary. 233. Endometrioma. This affects young women during their reproductive years and can cause chronic pelvic pain associated with menstruation. The traditional clinical history of endometriosis is the triad of infertility, dysmenorrhea, and dyspareunia. The buzzword classic appearance is rounded mass with homogeneous low-level internal echoes and increased through transmission, seen in 95% of cases. Fluid levels and internal septations can also be seen. It can look a lot like a hemorrhagic cyst, sometimes. As a general rule, the more unusual or varied the echogenicity and the more ovoid or irregular the shape, the more likely the mass is an endometrioma. Additionally, and of more practical value, they are not going to change on follow-up. Hemorrhagic cysts are. In about 30% of cases you can get small echogenic foci adhering to the walls. This helps make the endometrioma diagnosis more likely. Obviously, you want to differentiate this from a true wall nodule. The complications of endometriosis, bowel obstruction, infertility, etc., are due to a fibrotic reaction associated with the implant. The most common location for solid endometriosis is the uterosacral ligaments. Do endometrioma ever become cancer? About 1% of endometrioma undergo malignant transformation, usually endometrioid or clear cell carcinoma. How do you tell which one is which? Malignancy is very rare in endometrioma smaller than 6 centimeters. They usually have to be bigger than 9 centimeters. Additionally, the majority of women with carcinoma in an endometrioma are older than 45 years. So risk factors for turning into 234. Hemorrhagic cysts. Oh, get on mister to make sure it's not a derm ward plug. Oh, if it's not a derm ward, then call the surgeon. Serous ovarian isostadenocarcinoma isostadenoma. Serous tumors are the most common type of ovarian malignancy. About 60% of serous tumors are benign, and about 15% are considered borderline, the rest are malignant. They favor women of childbearing age, with the malignant ones tending to occur in older women. They typically are unilocular with few septations. They are frequently bilateral, especially when malignant. Papillary projections are a common finding, which suggests malignancy. If you see ascites, they have mets. 70% have peritoneal involvement at the time of diagnosis. Serous ovarian neoplasm large, unilocular, few septations. 237. 237. Mucinous ovarian cystadenocarcinoma. Often a large mass. They are typically multiloculated, although septa are often thin. Papillary projections are less common with serous tumors. You can see low-level echoes from mucin. These dudes can get pseudomyxoma peritonei with scalloping along solid organs. Smoking is a known risk factor, especially for mucinous types. This vs that, serous vs mucinous. Unilocular serous, mucinous, fewer septations, P-apt-hay projections common multilocular, more septations, papillary projections less common. Endometrioid ovarian cancer, this is the second most common ovarian cancer, serous number 1, mucinous number 3. These things are bilateral about 15%. 15% of the time. Time. What to know? "25% of women will have concomitant endometrial cancer. The endometrial cancer is the primary, ovary is met. Endometrioma can come into endometrioid cancer. 15% are bilateral. B.F.MS, for adults. It's useful to have a differential for a BFM. Big fucking mass, in an adult and a child. I discuss the child version of this on page 26. For adults, think about three main things. 1. Ovarian masses, mucinous and serous. 2. Desmoids, remember Gardner syndrome. 3. Sarcomas. Gamesmanship, ovarian mass and endometrial thickening. This is a way to show both endometrioid CA, which often has both ovarian and condytrial CA, and granulosa thicker cell tumor, which produce estrogen, and cause endometrial hyperplasia. 238. Fibroma I fibrothecoma. The ovarian fibroma is a benign ovarian tumor, most commonly seen in middle-aged women. The fibrothecoma I thecoma spectrum has similar histology. It's very similar to a fibroid. On ultrasound it's going to be hypoechoic and solid. On MRI it's going to be TL and T2 dark, with the band of T2 dark signal around the tumor on all planes. Calcifications are rare. Similar or related conditions. Meigs syndrome, this is the triad of ascites, pleural effusion, and a benign ovarian tumor, most commonly fibroma. Fibromatosis, this is a zebra. You have tumor-like enlargement of the ovaries due to ovarian fibrosis. It typically hits girls around the age of 25. It's associated with omental fibrosis, and sclerosing peritonitis. You are going to get dark TL and T2 signal. He buzzword for that T2 signal is black garland sign. The condition is benign, and sometimes managed with surgical removal of the ovaries. Brenner tumor, epithelial tumor of the ovary seen in women in their 50s to 70s. It's fibrous and T2 dark. Unlike fibroma, calcifications are common, 80%. They are also called ovarian transitional cell carcinoma for the purpose of fucking with you. Struma ovara 2, these things are actually a subtype of ovarian tratoma. On imaging you are looking for a multilocular, predominantly cystic mass with an intensely enhancing solid component. On MRT, the giveaway is very low T2 signal in the cystic areas, which is actually the thick colloid. These tumors contain thyroid tissue, and even though it's very rare, like 5%, I would expect that the question stem will lead you to this diagnosis by telling you the patient is hyperthyroid or in a thyroid storm. Metastatic disease to the ovary. Around 10% of malignant ovarian tumors are METs. The primary is most common from colon, gastric, breast, lung, and contralateral ovary. The most common look is bilateral solid tumors. Krukenberg tumor, this is a metastatic tumor to the ovaries from the GI tract, usually stomach. 239. Section 6 Random ovarian. Ovarian torsion. Rotation of the ovarian vascular pedicle, partial or complete, can result in obstruction to venous outflow and arterial inflow. Torsion is typically associated with a cyst or tumor, anything that makes it heavy, so it flops over on itself. Critical point equals the most constant finding in ovarian torsion is a large ovary. Features. Unilateral enlarged ovary, greater than 4 cm, mass on the ovary, peripheral cysts, free fluid, lack of arterial or venous flow. The ovary is not a testicle, the ovary has a dual blood supply. Just because you have flow, does not mean there isn't a torsion. You can torse and detorse. In other words, big ovary plus pain equals torsion. Clinical correlation recommended. Hydrosalpinx. Thin, or thick in chronic states, elongated tubular structure in the pelvis. The buzzword is cogwheel appearance, referring to the normal longitudinal folds of a fallopian tube becoming thickened. Another buzzword is string sign, referring to the incomplete septi. The waist sign describes a tubular mass with indentations of its opposing walls. This is supposed to help differentiate hydrosalpinx from an ovarian mass. There are a variety of causes. The most common is being a skank, infidel, or free spirit, PID. Additional causes include endometriosis, tubal cancer, post-hysterectomy, without oophorectomy, and tubal ligation. Rare and late complication is tubal torsion. 240. Pelvic inflammatory disease, PID. A plague on the dirty, slovenly, untidy woman. Infection or inflammation of the upper female genital tract. It's usually secondary to skank-like behavior, gonorrhea, or chlamydia. On ultrasound you are gonna get hydrosalpinx. The margin of the uterus may become ill-defined. Indefinite uterus is a buzzword. Later on you can end up with tubo-ovarian abscess or pelvic abscess. You can even get bowel or urinary tract inflammatory changes. Parovarian cyst. This is a congenital remnant that arises from the Wolffian duct. They are more common than you think, with some texts claiming these account for 10 to 20% of adnexal masses. They are classically round or oval, simple in appearance, and do not distort the adjacent ovary. Key finding. They can indent the ovary and mimic an exophytic cyst, but a good sonographer can use the transducer to separate the two structures. Ovarian vein thrombophlebitis. This is seen most commonly in postpartum women, often presenting with acute pelvic pain and fever. For whatever reason, 80% of the time it's on the right. It's most likely to be shown on CT, could be ultrasound, with a tubular structure with an enhancing wall and low attenuation thrombus in the expected location of the ovarian vein. A dreaded sequela is pulmonary embolus. 241. Peritoneal inclusion cyst. This is an inflammatory cyst of the peritoneal cavity that occurs when adhesions envelop an ovary. Adhesions can be thought of as diseased peritoneum. Whereas the normal peritoneum can absorb fluid, adhesions cannot. So, you end up with normal secretions from an active ovary confined by adhesions and resulting in an expanding pelvic mass. The classic history is patient with prior pelvic surgery. They have to tell you that, to clue you in on the presence of adhesions, now with pain. Alternatively, they could get tricky and say history of PID or endometriosis, some kind of inflammatory process to piss off the peritoneum. Then they will show an ultrasound, or Mr., with a complex fluid collection occupying pelvic recesses and containing the ovary. It's not uncommon to have septations, loculations and particulate matter within the contained fluid. Key features. 1. Lack of walls. They have a passive shape that conforms to and is defined by surrounding structures. 2. Entrapment of an ovary. Ovary will be either in the collection, or at the periphery. Peritoneal inclusion cyst adhesions around an ovary. 242. Gestational trophoblastic disease. Think about this with marked elevation of BHCG. They will actually trend betas for tumor activity. Apparently, elevated 8-HCG makes you vomit, so hyperemesis is often part of the given history. Another piece of trivia is that age over 40, and prior moles makes you more likely to get another mole. Hydatidiform mole. This is the most common form, and the benign form of the disease. There are two subtypes. Complete mole, classic mole, 70%. This one involves the entire placenta. There will be no fetus. The worthless trivia is that the karyotype is diploid. A total zebra scenario is that you have a normal fetus, with a complete mole twin pregnancy. If you see that in the wild, write it up. The pathogenesis is fertilization of an egg that has lost its chromosomes, 46XX. First trimester US, classically shows the uterus to be filled with an echogenic, solid, highly vascular mass, often described as snowstorm in appearance. Second trimester US, vesicles that make up the mole enlarge into individual cysts, 2-30 mm, and produce your bunch of grapes appearance. Partial mole, 30%. This one involves only a portion of the placenta. You do have a fetus, but it's all jacked up, triploid in karyotype. The pathogenesis is fertilization of an ovum by two sperm, 69XXY. Mercifully, it's lethal to the fetus. OUS, the placenta will be enlarged, and have areas of multiple, diffuse anechoic lesions. You may see fetal parts. Remember that I mentioned that fecal lutein cysts are seen in molar pregnancies. The piece of trivia is that they are actually most commonly seen in the second trimester, and are bilateral. Invasive mole. This refers to invasion of molar tissue into the myometrium. You typically see it after the treatment of a hydatidiform mole, about 0% of cases. US may show echogenic tissue in the myometrium. However, MRJ is way better at demonstrating muscle invasive. MRJ is going to demonstrate focal myometrial masses, dilated vessels, and areas of hemorrhage and necrosis. Choriocarcinoma. This is a very aggressive malignancy that forms only trophoblasts, no villous structure. The typical attacking pattern of choriocarcinoma is to spread locally, into the myometrium and parametrium, then to spread hematogenous to any site in the body. It's very vascular and bleeds like stink. The classic clinical scenario is serum HCG levels that rise in the 8 to 2 weeks following evacuation of molar pregnancy. On ultrasound, choriocarcinoma, at any site, results in a highly echogenic solid mass. Treatment equals methotrexate. 243. Sec 110N1 penis. Anatomy of this thing in cross-section. Urethra. Superficial fascia, deep fascia, tunica albuginea. Corpus cavernosum. Corpus spongiosum. Fractured penis. This is one of the most tragic situations that can occur in medicine. Can result from a variety of scenarios, but anecdotally seems to be most common in older men having extramarital sex with dirty strippers, while on Viagra and cocaine. They can show it on ultrasound, look for hematoma, or MRI, look for hematoma. The piece of trivia you should remember is this is defined by fracture corpus cavernosum and its surrounding sheath, the tunica albuginea. 244. Seeker 10NS prostate. Cancer. Biopsy of the prostate is a terrible, terrible situation, worse than anything you can imagine in a 1,000 years of hell. As a result, MRI of the prostate, instead of biopsy, is getting to be a hot topic. You can use prostate MRI for high-risk screening, high or rising PSA with negative biopsy, or to stage, look from extracapsular extension. First let's talk about prostate anatomy. Anatomists like to use zones to describe locations, and it actually helps with pathology. The anterior fibromuscular gland is dark on TL and T2. The central and transitional zones, together called the central gland, are brighter than the anterior muscular zone, but less bright than the peripheral zone on T2. In other words, the peripheral zone is the most T2 bright. Adenocarcinoma, peripheral zone, 70% transition zone, 20% central zone, 10%. Anterior fibromuscular zone. Centra 1G. LLNCTI, dash. Underscore, transitional zone, central zone. Dash J. Midland 1 dash dash dot. Apex F times. Peripheral zone minus 70% of prostate cancer is here minus 70% of gland mass. Dark stuff equals central gland, this is where BPH nodule have. Bright stuff equals peripheral zone, this is where cancer live. 245. Mr. finding or prostate CA, cancer is dark on T2, background is high, restricts on diffusion, low on ADC, and enhances early and washes out, type 3 curve, just like a breast cancer. Dark on T2, dark on ADC, restricts diffusion, enhances. Bone scan is the money for prostate mets, vertebral body mets. Staging. The main thing to know is stage B vs stage C, as extracapsular extension is the most important factor governing treatment. Stage 8. Confined by capsule. Abutment of the capsule without bulging. Stage C. Extension through capsule. Bulging of the capsule, or frank extension through it. Seminal vesicles and the nerve bundle are also right behind the prostate and can get invaded. Urologists love to hear about that. 246. BPH. Obviously this is super common, and makes old men pee a lot. Volume of 30 cc is one definition. Most commonly involves the transitional zone. Cancer is rare in the transition zone -10%. The median lobe is the one that hypertrophies and sticks up into the bladder. It can cause outlet obstruction, bladder wall thickening, detrusor hypertrophy, and development of diverticulum. The IVP buzzword is J-shaped or fishhook-shaped ureter. With regard to the BPH nodules you see on MRI, they are usually, in the transitional zone T2 heterogeneous, can restrict diffusion, may enhance and wash out. BPH nodules, bright eye heterogeneous shit in the central gland. Post-biopsy changes, this is going to be TL bright stuff in the gland. It's subacute blood. Prostate summary chart. T2 ADC enhancement, peripheral zone dark early tumor enhancement, early washout, peripheral zone dark, sometimes dark, less dark, non-hemorrhage T1 bright. Asterisk like after a biopsy. Central gland eye dark early transitional tone enhancement, tumor early washout, BPH dark less dark, can enhance defined. 247. Sec 110N9 misc male. Prostatic utricle cyst, Mullerian duct cyst. Some people try and distinguish between a prostatic utricle and a Mullerian duct cyst. They look very, very similar. The Mullerian duct cyst is an anatomic variant of the caudal ends of the Mullerian ducts, male equivalent of the vagina I cervix. The prostatic utricle is a focal dilation in the prostatic urethra. This can BPH. Obviously this is super common, and makes old men pee a lot. BPH. Obviously this is super common, and makes old men pee a lot. Volume of 30 cc is one definition. Most commonly involves the transitional zone. Cancer is rare in the transition zone -10%. The median lobe is the one that hypertrophies and sticks up into the bladder. It can cause outlet obstruction, bladder wall thickening, detrusor hypertrophy, and development of diverticulum. The IVP buzzword is J-shaped or fishhook-shaped ureter. With regard to the BPH nodules you see on MRI, they are usually, in the transitional zone T2 heterogeneous, can restrict diffusion, may enhance and wash out. BPH nodules, bright eye heterogeneous shit in the central gland. Post-biopsy changes, this is going to be TL bright stuff in the gland. It's subacute blood. Prostate summary chart. T2ADC enhancement, peripheral zone dark early tumor enhancement, early washout peripheral zone dark, sometimes dark, less dark, non-hemorrhage T1 bright. Asterisk like after a biopsy. Central gland eye dark charcoal dark early transitional tone enhancement, tumor early washout BPH dark well less dark can enhance defined. 247. Sec 110N9 misc male. Male. Prostatic utricle cyst Mullerian. Mullerian duct cyst. Some people try and distinguish between a prostatic utricle and a Mullerian duct cyst. They look very similar. The Mullerian duct cyst is an anatomic variant of the caudal ends of the Mullerian ducts, male equivalent of the vagina I cervix. The prostatic utricle is a focal dilation in the prostatic urethra. This can be shown with multiple imaging modalities. Think about it if you see a midline cystic structure near the bladder of a man. A sneaky trick would be to show it on a rug, where a prostate utricle cyst would look like a focal outpouching from the prostatic urethra. Things to know: prostatic utricle cyst hypospadias is the most common associated condition. Prune belly syndrome, Downs, unilateral renal agenesis, and Jumper-Jorotanus are also associated. If it's large, it can get infected. Things to know: Mullerian duct cyst does not have the same associations as utricle cyst. Can contain cancer, various types, endometrial, clear cell, squamous. Seminal vesicle cysts. The classic look is a unilateral cyst that is lateral to the prostate. If they get large they can look midline, but if they show you a large one you won't be able to tell it from the utricle cyst. They can be congenital or acquired. Congenital trivia: associated with renal agenesis, associated with vas deferens agenesis, associated with ectopic ureter insertion, associated with polycystic kidney disease. Acquired trivia: obstruction often from prostatic hypertrophy, or chronic irrefectional scarring. Classic history is prior prostate surgery. 248. Male pelvic cysts. Midline lateral. Prostatic utricle seminal vesicle cyst. Mullerian duct cyst, diverticulosis of the ampulla of vas deferens. Ejaculatory duct cysts. Testicular trauma: the big distinction is rupture vs fracture. Surgical intervention is required if there is testicular rupture. Intratesticular fracture and hematoma, small, do not get surgery. Rupture: disrupted tunica albuginea, heterogeneous testicle, poorly defined testicular outline. Fracture: intact tunica albuginea, linear hypoechoic band across the parenchyma of the testicle, well-defined testicular outline. Torsion of the testicle results from the testis and spermatic cord twisting within the serosal space, leading to ischemia. If it was 1950 you'd call in your nuclear medicine tech for scintigraphy. Now you just get a Doppler ultrasound. Findings will be absent or asymmetrically decreased flow, asymmetric enlargement and slightly decreased echogenicity of the affected testis. Cause: the bell clapper deformity, which describes an abnormal high attachment of the tunicle vaginalis, increases mobility and predisposes to torsion. It is usually a bilateral finding, so the contralateral side gets an orchiopexy. Viability: the viability is related to the degree of torsion, how many spins, and how long it has been spun. As a general rule, the surgeons try and get them in the OR before 6 hours. Epididymitis, inflammation of the epididymis, and the most common cause of acute onset scrotal pain in adults. In sexually active men the typical cause is chlamydia or gonorrhea. In older men it's more likely to be E. coli, due to an urinary tract source. The epididymal head is the most affected. Increased size and hyperemia are your ultrasound findings. You can have infection of the epididymis alone or infection of the epididymis and testicle. Isolated orchitis is rare. Orchitis typically progresses from epididymitis, isolated basically only occurs from mumps. It looks like asymmetric hyperemia. 249. Epidermoid cysts. This is a benign mass of the testicle, no malignant potential, with an aunt mini onion skin look, alternating hypoechoic and hyperechoic rings. It's relatively non-vascular relative to the rest of the testicle. Tubular ectasia of the rete testis. This is a common benign finding, resulting from obliteration, complete or partial, of the efferent ducts. It's usually bilateral, and in older men. The location of the cystic dilation is next to the mediastinum testis. Think about this as a normal variant. It requires no follow-up or further evaluation. Calcified vas deferens, you see this all. This all the time in bad diabetics. 250. Section 10. Gesticular cancer. Testicle cancer in the pediatric setting is discussed in the pediatric chapter. This discussion will focus on the adult subtypes, with some overlap. In general, hypoechoic solid intratesticular masses should be thought of as cancer until proven otherwise. Doppler flow can be helpful only when it is absent, can suggest hematoma, in the right clinical setting. If it's extratesticular and cystic, it's probably benign. The step 1 trivia is that cryptorchidism increases the risk of cancer, in both testicles, and is not reduced by orchiopexy. Most testicular tumors met via the lymphatics, retroperitoneal nodes at the level of the renal hilum. The testable exception is choriocarcinoma, which mets via the blood. Most testicular cancers are germ cell subtypes, 95%, with seminomas making up about half of those. Risk factors: cryptorchidism, for both testicles, gonadal dysgenesis, Klinefelters, trauma, orchitis, and testicular microlithiasis, maybe. Testicular microlithiasis, this appears as multiple small echogenic foci within the testes. Testicular microlithiasis is usually an incidental finding in scrotal US examinations performed for unrelated reasons. It might have a relationship with germ cell tumors, controversial. Follow-up in 6 months, then yearly is probably the recommendation, although this recommendation is controversial. Seminoma, this is the most common testicular tumor, and has the best prognosis as they are very radiosensitive. They are much more common, 9x, in white people. The classic age is around 25. It usually looks like a homogeneous hypoechoic round mass, which classically replaces the entire testicle. On MRI they are usually homogeneously T2 dark, non-seminomatous GCTs are often higher in signal. 251. Non-seminomatous germ cell tumors, basically this is not a seminoma. We are talking about mixed germ cell tumors, tritomas, yolk sac tumors, and choriocarcinoma. They typically occur at a young age relative to seminomas, think teenager. They are more heterogeneous and have larger calcifications. Testicular lymphoma: just be aware that lymphoma can hide in the testes because of the blood-testes barrier. Immunosuppressed patients are at increased risk for developing extranodal /testicular lymphoma. Almost all testicular lymphomas are non-Hodgkin B-cell subtypes. On US, the normal homogeneous echogenic testicular tissue is replaced focally or diffusely with hypoechoic vascular lymphomatous tissue. Buzzword equals multiple hypoechoic masses of the testicle. Burned out testicular tumor: if you see large dense calcifications with shadowing in the testicle of an old man, this is probably what you should be thinking. The idea is that you've had spontaneous regression of a germ cell testicular neoplasm, that is now calcified. An important pearl is that there can still be viable tumor in there. Management is somewhat controversial and unlikely to be asked, most people pull them out. Staging pearl. Testicular mets should spread to the para-aortic, aortic, Caval region. It's an embryology thing. If you have mets to the pelvic, external iliac, and inguinal nodes, this is considered non-regional IEM1 disease. The exception is some kind of inguinal or scrotum surgery was done before the cancer manifested, but I wouldn't expect them to get that fancy on the test. Just remember inguinal pelvic nodes are non-regional and a higher stage, M1. 252. High-yield testicle tumor trivia. Seminoma is the most common, and has the best prognosis. It melts with radiation. Multiple hypoechoic masses equals lymphoma. Homogeneous and microcalcifications equals seminoma. Cystic elements and macrocalcifications equals mixed germ cell tumor / tratoma. Most testicular tumors met via the lymphatics. Choriocarcinoma mets via the blood, and tends to bleed like stink. Gynecomastia can be seen with Sertoli liditumors. Sertoli cell tumors are also seen with Pustulas. Elevated HCG. Seminoma. Choriocarcinoma. Seminoma. Lymphoma. Elevated AFP. Mixed germ cell yolk sac. Mixed germ cell / tratoma. 253. Section 11. Male infertility. Causes can be thought of as obstructive vs non-obstructive. Obstructive, congenital bilateral absence of the vas deferens, seen in cystic fibrosis, ejaculatory duct obstruction, prostatic cysts. Think about associated renal anomalies, Zinner syndrome. Non-obstructive, varicocele, cryptorchidism, anabolic steroid use, erectile dysfunction. Varicocele, this is the most common correctable cause of infertility. They can be unilateral or bilateral. Unilateral is much more common on the left. Isolated right-sided should make you think retroperitoneal process compressing the right gonadal vein. Cryptorchidism, undescended testes. The testicle is usually found in the inguinal canal. The testicle has an increased risk of cancer. Actually they both will, which is weird. It's most commonly seen in premature kids, 20%. Major complication association for cryptorchidism, malignant degeneration, of both the undescended and contralateral testicle. Infertility. Torsion. Bowel incarceration, related to the association of indirect inguinal hernia. Gamesmanship, a good distractor would be orchitis. It's a pathology that involves that balls, so it's not totally far-fetched. Obviously they can get orchitis, but not at a higher rate. It's not a reported association, so don't fall for that. Zebras and syndromes associated with male infertility. Pituitary adenoma making prolactin chi / Mann's syndrome, can't smell and infertile, Klinefelter's syndrome, Talge and gynecomastia and infertile, Zinner syndrome, renal agenesis and ipsilateral seminal vesicle cyst. 254. Section 12(0)(b). Early pregnancy. Vocab. Menstrual age, embryologic age plus 14 days. Embryo, 0 to 10 weeks, menstrual age, fetus. 10 weeks, menstrual age, threatened abortion, bleeding with closed cervix. Inevitable abortion, cervical dilation and / or placental and / or fetal tissue hanging out. Incomplete abortion, residual products in the uterus. Complete abortion, all products out. Missed abortion, fetus is dead, but still in the uterus. Intradecidual sign. This is the early gestational sac. When seen covered by echogenic decidua is very characteristic of early pregnancy. You can see it around 4.5 weeks. You want to see the thin echogenic line of the uterine cavity pass by, not stop at the sac to avoid calling a little bit of fluid in the canal sac. Double decidual sac sign. This is another positive sign of early pregnancy. It's produced by visualizing the layers of decidua. Ultradiciddual sign. Small amount of fluid between. Decidual capsularis. Double decidual sac sign. 255. Yolk sac. This is the first structure visible within the GS. The classic teaching was you should always see it when the GS measures 8 mm in diameter. The thing should be oval or round, fluid-filled, and smaller than 6 mm. The yolk sac is located in the chorionic cavity, and hooked up to the umbilicus of the embryo by the vitellin duct. Yolk sac gone bad. The yolk sac shouldn't be too big, 6 mm, shouldn't be too small. The amnion. The membranes of the amniotic sac and chorionic space typically remain separated by a thin layer of fluid, until about 14 to 16 weeks, at which point fusion is normal. If the amnion gets disrupted before 10 weeks, the fetus might cross into the chorionic cavity and get tangled up in the fibrous bands. This is the etiology of amniotic band syndrome, which can be terrible: decapitation, limb amputation, etc. Yolk sac, in the chorionic cavity. A equals amniotic space. Arrow equals amnion. C equals chorionic space. Double blib sign, this is the earliest visualization of the embryo. This is two fluid-filled sacs, yolk and amniotic, with the flat embryo in the middle. Early embryo amniotic sac. Placenta site. Double blib sign. 256. Crown rump length. This is typically used to estimate gestational age, and is more accurate than menstrual history. Asterisk embryo is normally visible at 6 weeks. An embryonic pregnancy, a gestational sac without an embryo. When you see this, the choices are A. Very early pregnancy, or B. Non-viable pregnancy. The classic teaching was you should see the yolk sac at 8 mm, on TV. Just remember that a large sac, 8 to 10 mm, without a yolk sac, and a distorted contour is pretty reliable for a non-viable pregnancy. Pseudogestational sac, this is not the same thing as an anembryonic pregnancy. This is seen in the presence of an ectopic pregnancy. What you are seeing is a little bit of blood in the uterine cavity with surrounding bright decidual endometrium, charged up from the pregnancy hormones. Subchorionic hemorrhage, these are very common. The thing to know is that the percentage of placental detachment is the prognostic factor most strongly associated with a fetal demise. Hematoma greater than 2/3 the circumference of the chorion has a 2x increased risk of abortion. Other trivia: women older than 35 have worse outcomes with these. Implantation bleeding, this isn't a specific term referring to a small subchorionic hemorrhage that occurs at the attachment of the chorion to the endometrium. 257. Old criteria for fetal demise vs new criteria for fetal demise. They have recently, very recently, redone the numbers for calling it non-viable, and I'm not sure which version will be tested, so I'm presenting both. For the most part, the new ones give more wiggle room. Most recent guideline for fetal demise: old school, traditional, maybe too new for core, guidelines for abnormal pregnancy. Diagnostic of pregnancy: suspicious for pregnancy failure. Crown rump length of 7 mm, no embryo 6 WK after last absent yolk sac with MSD, and no heartbeat, menstrual period 8 mm. Mean sac diameter of 2.5 mm, mean sac diameter of 16 to 24, absent embryo when MSD, and no embryo millimeter and no embryo 16 mm. No embryo with heartbeat 11, no embryo with heartbeat 13, no cardiac activity when days after a scan that showed a embryo can be seen on gestational sac with a yolk sac, gestational sac without a yolk, transabdominal, or SMM on sac TV. 5 alive. No embryo with heartbeat 2, no embryo with heartbeat I0 ***, always give 1-2 mm as the WK after a scan that showed a benefit of doubt. Gestational sac without a yolk, gestational sac with a yolk sac Daubilit, Peter M. et al. Diagnostic criteria for non-viable pregnancy early in the first trimester. New England Journal of Medicine 369.15, 2013, 1443 to 1451. 258. Ectopic. High risk for ectopic, HX of PID, tubal surgery, endometriosis, ovulation induction, previous ectopic, use of an IUD. The majority of ectopic pregnancies, nearly 95%, occur in the fallopian, usually the isthmic portion. A small percentage, around 2%, are interstitial, developing in the portion of the tube which passes through the uterine wall. These interstitials are high risk, as they can grow large before rupture, causing a catastrophic hemorrhage. It is also possible, although very rare, to have implantation sites in the abdominal cavity, ovary, and cervix. Always start down the ectopic pathway with a positive BHCG. At around 1500 to 2000 MIU/L you should see a gestational sac. At around 5000 M, You should see a yolk sac. As a general rule, a normal doubling time makes ectopic less likely. Tubal ring sign, an echogenic ring, which surrounds an UN ruptured ectopic pregnancy. This is an excellent sign of ectopic pregnancy, and has been described as 95% specific. Heterotopic pregnancy, this is a baby in the uterus and a baby in the tube, or other ectopic location. This is pretty rare, and typically only seen in women taking ovulation drugs, or prior bad PID. Ring sign in the region of the tube. The big three to remember with ectopics: positive BHCG. Live pregnancy. Yolk sac outside the uterus equals slam dunk. 2. Nothing in the uterus plus anything on the adnexar, other than corpus luteum, equals 75 to 85% ppv for ectopic A. A moderate volume of free fluid increases this to 97% ppv. 3. Nothing in the uterus plus moderate free fluid equals 70% ppva. More risk if the fluid is echogenic. 259. Fetal biometry and fetal growth. In the second and third trimesters, 4 standard measurements of fetal growth are made: biparietal, head circumference, abdominal circumference, and femur length. The testable trivia seems to include what level you make the measurement, and what is and is not included. See chart. Fetal measurement for growth. Recorded at the level of the thalamus from the outermost edge of the near skull to the inner table of the far skull. Head circumference recorded at the same does not include. I slice as BPD the skin TI abdominal, recorded at the level 1 knows not include, circumference of the junction of the times the subcutaneous soft. Affected by the shape of the fetal skull, false large from brachycephaly, false J small from idolichocephaly. Affected less by head shape. I equals LF Euro F1, C Zisk. Underscore underscore. 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 Estimated fetal weight. This is calculated by the machine-based or either 1. BPD and AC, or 2. AC and FL. Gestational age. GA ultrasound estimates of gestation age are the most accurate in an early pregnancy, and become less precise in the later portions. Age in the first trimester is made from crown rump length. Second and third trimester estimates for age are typically done using BPD, HC, AC, and FL and referred to as a composite GA. Gestation age, less good later in the pregnancy. First trimester crown rump length J accurate to 0.5 weeks 1 accurate to L 2 weeks, age 12 and I equals I. 2 degree D and third trimester, composite GA. Times intrauterine growth restriction. Readings suggestive of IUGR. Estimated fetal weights below 10th percentile femur length I abdominal circumference ratio, F/AC, 23.5 umbilical artery systolic I diastolic ratio, 4.0. Not all is lost. If the kid is measuring small, he might just be a little guy. LFHE has normal Doppler studies, most of the time they are okay. Maybe all is lost, if the kid is measuring small, suggesting IUGR, and he has oligohydranios, AFI. Trivia: most common cause for developing oligohydranios during the third trimester equals fetal growth restriction associated with placental insufficiency. Symmetrical vs asymmetrical. Asymmetrical, think about this as a restriction of weight followed by length. It is the more common of the two types. The head will be normal in size, with the body being small. Some people call this head sparing. sparing as the body tries to protect the brain. You see this mainly in the third trimester, as a result of extrinsic factors. The classic scenario would be normal growth for the first 2 trimesters, with a normal head, small body, small abdominal circumference, in the third trimester, with a mom having chronic high BP preeclampsia. There are a bunch of causes. I recommend remembering these 3: high BP, severe malnutrition, elodan loss. Symmetric, this is a global growth restriction that does not spare the head. Head. This is seen throughout the pregnancy, including the first trimester. The head and body are both small. This has a much worse prognosis, as the brain doesn't develop normally. There are also a bunch of causes. I recommend remembering these: torch infection, fetal alcohol syndrome, drug abuse, chromosomal abnormalities, and anemia. 261. Intrauterine growth retardation cont. Normal kid, normal-sized head, normal-sized body. Symmetric IUG, small head, skinny body, same throughout pregnancy. Syphilis, among other torches, Scotch whiskey, fetal itoh, some extra chromosomes. Asymmetric IUG, abdomen is small, aching belly, malnutrition, abnormally high BP, elastic skin, elodantos, asymmetric time interval, primarily seen in third trimester. 262. Umbilical artery systolic eye diastolic ratio, the resistance in the umbilical artery should progressively decrease with gestational age. The general rule is 2 to 3 at 32 weeks. The ratio should not be more than 3 at 34 weeks. An elevated S/D ratio means there is high resistance. High resistance patterns are seen in preeclampsia and IUGR. Worse than an elevated ratio is absent or reversed diastolic flow. This is associated with a very poor prognosis. The way I remember this, I think about the kid starting out as a clump of cells / mashed up soup. Early on he/she is basically just a muscle. Then as he/she gets closer and closer to viable age, he/she becomes more like a brain. Once you think about it like that, muscle vs brain, it's much easier to understand why the diastolic flow goes up, S/D ratio goes down. Remember, the brain is always on, so it needs continuous flow. Muscles are only on when you need to perform amazing feats of strength. So more brain equals more diastolic flow. This also explains why absent or reversed diastolic flow is so devastatingly bad. In fact, the evil socialist healthcare systems in Europe use carotid ultrasound as a cheap brain death test. No diastolic flow in the ICA equals brain dead. Coincidentally, the absence of diastolic flow in the ICA is also used in many American radiology departments as hiring criteria for the QA officer. 263. Biophysical profile. This thing was developed to look for acute and chronic hypoxia. Points are assigned: 2 for normal, 0 for abnormal. A score of 8 to 10 is considered normal. To call something abnormal, technically you have to be watching for 30 minutes. Amniotic fluid components of biophysical profile. Profile. J. At least one pocket that measures I. Assess chronic hypoxia. LJ 2 cm or more in a vertical plane. I times, -I. Fetal movement. I. 3 discrete movements. Assess acute hypoxia. I. Fetal tone. I. Episode of fetal extension from. Assess acute H. 11. -1 J __ flexion times ____ times times ____ fetal breathing. 11 episode of breathing motion. J. Assess acute hypoxia. L1 lasting 30 EC ___ S ____ macrosomia, babies that are too big, above the 90th percentile. Maternal diabetes, usually gestational, but could be type 2 as well, is the most common cause. As a point of trivia, type 1 diabetic mothers can also have babies that are small secondary to hypoxia from microvascular disease of the placenta. The big issue with being too big is complications during delivery, shoulder dystocia, brachial plexus injury, and after delivery, neonatal hypoglycemia, meconium aspiration. Erb's palsy, injury to the upper trunk of the brachial plexus, C5-C6, most commonly seen in shoulder dystocia, which kids with macrosomia are higher risk for. If you see an aplastic or hyperplastic humeral head idalcnoid in a kid, you should immediately think about an Erb's palsy. Clinical correlation recommended. 264. Amniotic fluid. Early on, the fluid in the amnion and chorionic spaces is the result of filtrate from the membranes. After 16 weeks, the fluid is made by the fetus, urine. The balance of too much, polyhydramnios, and too little, oligohydramnios, is maintained by swallowing of the urine and renal function. In other words, if you have too little fluid, you should think kidneys aren't working. If you have too much fluid, you should think swallow or other GI problems. Having said that, a common cause of too much fluid is high maternal sugars, gestational diabetes. Fine particulate in the fluid is normal, especially in the third trimester. Amniotic fluid index, made by measuring the vertical height of the deepest fluid pocket in each quadrant of the uterus, then summing the four measurements. Normal is 5 to 20. Oligohydramnios is defined as AFI 20 cm, or a single fluid pocket, 8 cm. Oligohydramnios AFI. Polyhydramnios AFI, 20 or single pocket, burn. Not PN enough, bad kidneys. Not drinking enough P, bad GI. 265. Normal development. I'm going to briefly touch on what I think is testable trivia regarding normal development. Brain, choroid plexus is large and echogenic. There should be less than 3 mm of separation of the choroid plexus from the medial wall of the lateral ventricle, if more it's ventriculomegaly. The systema magna should be between 2 mm 1 mm, too small think Chiari-2, too large think Dandy Walker. Face eye neck, the fulcrum of the upper lip is normal, and should not be called a cleft lip. Lungs, the lungs are normally homogeneously echogenic, and similar in appearance to the liver. Heart, the only thing to know is that a papillary muscle can calcify echogenic foci in the ventricle, and although this is common and can mean nothing, it's also associated with an increased risk of Downs. Look hard for other things. Abdominal, if you only see one artery adjacent to the bladder, you have yourself a two-vessel cord. Bowel should be less than 6 mm in diameter. Bowel can be moderately echogenic in the second and third trimester but should never be more than bone. The adrenals are huge in newborns, and are said to be 20x their relative size. Two-vessel cord, gamesmanship. There are two main ways to show a two-vessel cord. The first one is a single vessel running lateral to the bladder down by the cord insertion. The second is to show the cord in cross-section with two vessels. More on the two-vessel cord in a few pages. Cord in cross-section, only two vessels. 266. Classic normal pictures that look scary. Cystic rhombencephalon, the normal rhombencephalon is present as a cystic structure in the posterior fossa around 6 to 8 weeks. Don 1 call to a Dandy Walker /formation, for sure that will be a distractor. Normal cystic rhombencephalon, 6 to 8 weeks. Physiologic midgut herniation, the midgut normally herniates into the umbilical cord around 9 to 11 weeks. Don 1 call it an omphalocele. For sure that will be a distractor. Normal midgut herniation, 9 LL weeks. 267. Section 13. Placenta. Placenta and umbilical cord. Cord. Placenta. Normal, you can first start to see the placenta around 8 weeks, focal thickening along the periphery of the gestational sac. It should be shaped like a disc around 12 weeks. The normal sonographic appearance is granular with a smooth cover, the chorion. Underneath the basal surface there is a normal retroplacental complex of decidual and myometrial veins. Normal placenta aging, as the placenta ages it gets hypoechoic areas, septations, and randomly distributed calcifications. Venous lakes, these are an incidental finding of no significance. They look like focal hypoechoic areas under the chorionic membrane, or within the placenta. You can sometimes see slow flow in them. Placental thickness too thin, 4 cm, placental insufficiency, maternal fetal hydrops, maternal OM. Severe hypertension, maternal OM, trisomy 13, maternal anemia, congenital fetal cancer. Trisom _Y18, toxemia of pregnancy neonatal infection, placental abruption. Variant placental morphology. Bilobed placenta. Placenta. Subcentriate lobe. Lobe. Circumvallate placenta. Placenta. 2 near equal-sized lobes. 1 or more small. Subcentriate lobe. Circumvallate placenta. 2 near equal-sized lobes. 1 or more small accessory lobes. Increased risk of type 2 vasa previa, postpartum hemorrhage from retained placental tissue, and clematis insertion of the cord. Increased risk of type 2 vasa previa, postpartum hemorrhage from retained placental tissue, rolled placental edges. 11. I risk for placental abruption and with smaller chorionic IUG are late. Placenta previa. Previa. This is a low implantation of the placenta that covers part of or all of the internal cervical OS. The clinical buzzword is painless vaginal bleeding in the 3rd trimester. A practical pearl is that you need to have an empty bladder when you look for this. Full bladder creates a false positive. 268. Placental abruption. This is a premature separation of the placenta from the myometrium. The step L history was always mother doing cocaine, but it also occurs in the setting of hypertension. Technically, subchorionic hemorrhage, marginal abruption, is in the category, as previously discussed. Retroplacental abruption is the really bad one. The hematoma will appear as an echoic or mixed echogenicity beneath the placenta, often extending beneath the chorion. Buzzword is disruption of the retroplacental complex. Placental abruption vs myometrial contraction I fibroid. Placental abruption will disrupt the retroplacental complex of blood. Myometrial contractions I fibroids will displace the retroplacental L vessels complex. Placenta creta. This is an abnormal insertion of the placenta, which invades the myometrium. The severity is graded with fancy-sounding Latin names. The risk factors include prior C-section, placenta previa, and advanced maternal age. The sonographic appearance varies depending on the severity, but generally speaking you are looking for a moth-eaten or Swiss cheese appearance of the placenta, with vascular channels extending from the placenta into the myometrium, with turbulent flow on Doppler. Thinning of the myometrium, less than IM, is another sign. This can be serious business, with life-threatening bleeding sometimes requiring hysterectomy. The big risk factor is prior C-section, and placenta previa. I placenta accreta. Placental creta. I placenta pcacreta. I most common, 75%, and mildest form. The villi attach to the myometrium. Without invading. Villi partially invade the myometrium. The really bad one. Villi penetrate through the myometrium or beyond the serosa. Sometimes there is invasion of the bladder or bowel. ___________J. Normal accretal creta per creta. Endometrium. Myometrium. Serosa. 269. Placenta chorioangioma. This is basically a hematoma of the placenta, and is the most common benign tumor of the placenta. These are usually well circumscribed hypoechoic masses near the cord insertion. Flow within the mass pulsating at the fetal heart rate is diagnostic. They are perfused by the fetal circulation. They almost always mean nothing, but if they are large, 4 cm, and multiple, chorioangiomatosis, they can sequester platelets, and cause a high output failure, high drops. Placental chorioangioma vs placental hematoma. Chorioangioma has pulsating Doppler flow, hematoma does not have pulsating Doppler flow. 270. Umbilical cord. Normal cord should have 3 vessels, 2 arteries, 1 vein. 2-vessel cord. This is a normal variant, seen in about 1% of pregnancies. Usually the left artery is the one missing. This tends to occur more in twin pregnancies and maternal diabetes. There is an increased association with chromosomal anomalies and various fetal malformations, so look closely. Having said that, in isolation it doesn't mean much. Velamentous cord insertion. This is the term for when the cord inserts into the fetal membranes outside the placental margin, and then has to travel back through the membranes to the placenta, between the amnion and the chorion. It's more common with twins, and increases the risk of intrauterine growth restriction and growth discordance among twins. Marginal cord insertion. This is basically almost a velamentous insertion. Cord is within 2 cm of the placental margin. It's also seen more in twin pregnancies. Normal. // I. Marginal I backslash. I backslash I backslash I. I. Verlamentous. Vasa previa, fetal vessels that cross, or almost cross, the internal cervical os. It's seen more in twin pregnancies, and variant placental morphologies. There are two types. Type L, fetal vessels connect to a verlamentous cord insertion within the main body of the placenta. Type 2, fetal vessels connect to a bilobed placenta or sexcentriate lobe. Nuchal cord, this is the term used to describe a cord wrapped around the neck of the fetus. Obviously this can cause problems during delivery. Umbilical cord cyst, these are common, seen about 3% of the time, and are usually single, but can be multiple. As a point of completely irrelevant trivia, you can divide these into false and true cysts. True cysts are less common, but have fancy names, so they are more likely to be tested. Just know that the omphalomxenteric duct cyst is usually peripheral, and the allantoic cyst is usually central. If the cysts persist into the second or third trimester, then they might be associated with trisomy 18 and 1-3. You should look close for other problems. 271. Section 14 Congenital fetal anomalies. Downs. Ultrasound findings concerning for Down syndrome congenital heart disease. Duodenal ataxia. Short femur length. Echogenic bowel. Choroid plexus cyst. Nuchal translucency, nuchal fold thickness. More than half of fetuses, or feti, if you prefer, with Downs have congenital heart issues. Most commonly AV canal and VSD, most common intra-abdominal pathology associated with Downs, hard to see before 22 weeks, not specific, not specific, can be seen with obstruction, infection, CF ischemia, and lots of other stuff, not specific, and actually seen more with trisomy 18. It should prompt a close survey for other findings, normal if in isolation, translucency, 3 mm in the first trimester, thickness, 6 mm in the second trimester, not specific, and can also be seen with Turner's echogenic focus in cardiac ventricle, not specific, but increased risk of Downs X4. Anechoic lucency, measured between 9 to 12 weeks, this anechoic area between the neck/occiput and the skin should be less than 3 mm. Measurements, 3 mm are associated with Downs, trisomy 21, or other chromosomal abnormalities. Positioning of the neck is critical to avoid false positives. The ideal positioning is a neutral neck, with the nasal bone visualized, and the head in the mid-sagittal position. A well-delineated skin edge. Maternal blood sample also analyzed for free beta-HCG and pregnancy-associated plasma protein A, PAP-A. 272. Amniotic band syndrome. The fetus needs to stay in the amniotic cavity, and stay the hell out of the chorionic cavity. If the amnion gets disrupted and the fetus wanders floats into the chorionic cavity, he/she can get caught in the sticky fibrous septa. All kinds of terrible can result, ranging from decapitation, to arm/leg amputation. This is most likely to be shown in one of two ways. 1. An X-ray of a hand or babygram showing fingers amputated or a hand/arm amputated with the remaining exam normal, or 2. A fetal ultrasound with the bands entangling the arms or legs of a fetus. Amniotic band syndrome, amputated fingers. Hydrops. Fetal hydrops is bad news. This can be from immune or non-immune causes. The most common cause is probably RH sensitization from prior pregnancy. Some other causes include torches, Turner's, twin-related stuff, and alpha thalassemia. Ultrasound diagnosis is made by the presence of two of the following: pleural effusion, pericardial effusion, and subcutaneous edema. A sneaky trick is to instead show you a thickened placenta, 4-5 cm, although I think it's much more likely to show a pleural effusion and pericardial effusion. Hydrops, body wall edema, pleural effusion, ascites. Section 14 Congenital fetal anomalies. Downs. Ultrasound findings concerning for Down syndrome congenital heart disease. Duodenal ataxia. Short femur length. Echogenic bowel. Choroid plexus cyst. Nuchal translucency, nuchal fold thickness. More than half of fetuses, or feti, if you prefer, with Downs have congenital heart issues. Most commonly AV canal and VSD, most common intra-abdominal pathology associated with Downs, hard to see before 22 weeks, not specific, not specific, can be seen with obstruction, infection, CF ischemia, and lots of other stuff, not specific, and actually seen more with trisomy 18. It should prompt a close survey for other findings, normal if in isolation, translucency, 3 mm in the first trimester, thickness, 6 mm in the second trimester specific and can also be seen with Turner's echogenic focus in cardiac ventricle not specific, but increased risk of Downs X4. Anechoic lucency, measured between 9 to 12 weeks. This anechoic area between the neck/occiput and the skin should be less than 3 mm. Measurements: 3 mm are associated with Downs, trisomy 21, or other chromosomal abnormalities. Positioning of the neck is critical to avoid false positives. The ideal positioning is a neutral neck, with the nasal bone visualized, and the head in the mid-sagittal position. A well-delineated skin edge. Maternal blood sample also analyzed for free beta-HCG and pregnancy-associated plasma protein A, PAP-A. 272. Amniotic band syndrome. The fetus needs to stay in the amniotic cavity, and stay the hell out of the chorionic cavity. If the amnion gets disrupted and the fetus wanders into the chorionic cavity, he/she can get caught in the sticky fibrous septa. All kinds of terrible can result, ranging from decapitation, to arm/leg amputation. This is most likely to be shown in one of two ways. 1. An X-ray of a hand or babygram showing fingers amputated or a hand/arm amputated with the remaining exam normal, or 2. A fetal ultrasound with the bands entangling the arms or legs of a fetus. Amniotic band syndrome, amputated fingers. Hydrops. Fetal hydrops is bad news. This can be from immune or non-immune causes. The most common cause is probably Rh sensitization from prior pregnancy. Some other causes include Torch's, Turner's, twin-related stuff, and alpha thalassemia. Ultrasound diagnosis is made by the presence of two of the following: pleural effusion, pericardial effusion, and subcutaneous edema. A sneaky trick is to instead show you a thickened placenta, 4-5 cm, although I think it's much more likely to show a pleural effusion and pericardial effusion. Hydrops, body wall edema, pleural effusion, ascites. 273. Chiari2I open neural tube defect. I think at least some general idea on the mechanism for this pathology is helpful for understanding the ultrasound findings. There are a bunch of purposed mechanisms, and of course they all think they are right. I don't give a shit which one is the real mechanism, I just picked the one that helps me understand the findings. So this is the one I like. You have a hole in your back from a neural tube defect. Step 1 trivia equals not enough folate. The hole in your back myelomeningocele lets CSF drip out. So you end up with a low volume of CSF. The CSF volume needs to be at a certain pressure to distend the ventricular system. If it's underdistended, then the hindbrain structures drop into a caudal position. This caudal herniation of the cerebellar vermis, brainstem, and fourth ventricle are the hallmark of Chiari2. This caudal herniation of the cerebellum into the foramen magnum obliterate the normal contour of the vermis, creating the contour of a banana. If you can think about a normal pressure in the developing ventricular system being necessary for the brain to stretch into a normal shape, then it isn't a far stretch to think about this normal pressure being needed to shape the skull correctly too. The low pressure and abnormal distension of the developing brain results in incomplete stretching of the postal, front part, skull. The result is a lemon-shaped rostral skull. The key point, testable, is that this lemon shape goes away in the third trimester. So it's only present in the second trimester. The way I remember this is that the problem was from a lack of volume. Once the brain grows big enough, even if there isn't enough CSF distension, it still gets 273. CRE2I open neural tube defect. I think at least some general idea on the mechanism for this pathology is helpful for understanding the ultrasound findings. There are a bunch of purposed mechanisms, and of course they all think they are right. I don't give a shit which one is the real mechanism, I just picked the one that helps me understand the findings. So this is the one I like. You have a hole in your back from a neural tube defect. Step 1 trivia equals not enough folate. The hole in your back myelomeningocele lets CSF drip out. So you end up with a low volume of CSF. The CSF volume needs to be at a certain pressure to distend the ventricular system. If it's underdistended, then the hindbrain structures drop into a caudal position. This caudal herniation of the cerebellar vermis, brainstem, and fourth ventricle are the hallmark of CRE2. This caudal herniation of the cerebellum into the foramen magnum obliterate the normal contour of the vermis, creating the contour of a banana. If you can think about a normal pressure in the developing ventricular system being necessary for the brain to stretch into a normal shape, then it isn't a far stretch to think about this normal pressure being needed to shape the skull correctly too. The low pressure and abnormal distension of the developing brain results in incomplete stretching of the postal, front part, skull. The result is a lemon-shaped rostral skull. The key point, testable, is that this lemon shape goes away in the third trimester. So it's only present in the second trimester. The way I remember this is that the problem was from a lack of volume. Once the brain grows big enough, even if there isn't enough CSF distension, it still gets big enough to put a normal curve on that rostral skull. So they grow out of it. Testable trivia, both banana and lemon signs are classic for the CRE2I spina bifida path. The banana sign is present in both second and third trimesters. The lemon sign is only in the second trimester. You grow out of it. The banana sign is more sensitive and specific. The lemon sign is less sensitive and specific. It can also be seen sometimes in Dandy Walker, absent corpus callosum, encephalocele etc. Having said that, if you see it on the test, it's CRE2 plus open NTD. Hydrocephalus is also seen with CRE2 plus open NTD, but only later in gestation, and only when it's severe. 274. Open neural tube defect. Low CSF pressure during development. CRE2. Banana loss of the normal biforward/abed shaped of the cerebellum. This is what it's supposed to look like. Normal bilobed shaped of the cerebellum cavum septum pellucidum. Lemon flat eye concave frontal bones. Normal shape of the frontal bone. 275. Ventriculomegaly. There are multiple causes including hydrocephalus, both communicating and non-communicating, and cerebral atrophy. Obviously this is bad, and frequently associated with anomalies. Things to know.